Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. On the podcast today, I'm joined by our deputy editor, Nick Bostock.
Hiya.
And senior reporter, Kimberley Hackett.
Hello everyone.
To talk about some of the key news stories affecting general practice. Coming up, we're talking about advice and guidance after NHS England was forced to clarify that there was no national target for diverting GP referrals. Alongside this, we're looking at some new guidance from the BMA on advice and guidance, and also whether GPs have been involved locally with the development of controversial single point of access systems that NHS England says will overhaul referrals. We'll also be talking about the state of the GP partnership model after we ran a story last week about a private company, Operose, approaching GP partners with the offer to liberate them from the pressures of running and practice, as well as a brief look ahead to the UK LMCs conference which starts on the 13th of May. Our good news story this week is about a practice in North Yorkshire that has been saved from closure. GP Online has joined forces with 5 essential healthcare resources to create the MIMS Healthcare Network. Since 1959, our Haymarket healthcare titles have supported primary and secondary care audience across the UK through individual publications and specialist events. We're now entering an exciting new era with the launch of MIMS Healthcare Network, linking together our 6 leading media brands to serve the entire healthcare community as one. The MIMS Healthcare Network covers GP Online, GP Business, MIMS, MIMS Learning, MIMS Learning Live and MIMS Pharma. By bringing together these resources, we aim to provide a seamless experience for all healthcare professionals and the organisations that support and supply the UK health sector. The MIMS Healthcare Network, covering every aspect of primary care. For more information about our subscriptions, visit GPonline.com/subscribe. First up, let's talk about advice and guidance. So, Nick, this was one of the really controversial parts of this year's GP contract, wasn't it? Last year, advice and guidance was an enhanced service worth around £80 million, and GPs were paid per request they submitted. This year, that money's been moved into core funding, effectively making it mandatory, and meaning there's obviously no cap on the potential workload that comes with it. At the same time, we've seen that the government and NHS England talk about this ambition for 25% of referrals to be diverted, effectively meaning, they never see a specialist. Obviously, this caused a lot of concern among GPs, which we've talked about on the podcast before, but there's been some developments on this recently. What's happened?
The BMA England GP Committee has been in talks with the government since about the middle of April, which was when Parliament's Easter recess came to an end. The government offered talks to discuss a framework for a major GP contract reform that it's agreed to negotiate with the BMA by the end of the current Parliament. And the BMA said yes to talks, but it said it wanted assurances on 2 key points before it would get into discussions about the big new contract idea. Those 2 points are basically at the heart of why general practice is currently in dispute with the government and why GPs voted to reject the contract package imposed by the government for the 2026-27 financial year. The 2 BMA asks were that the government should agree measures to mitigate unmanageable workload for GP practices linked to new contract requirements, and that it back down over changes to advice and guidance that GPs fear will undermine their right to refer. On the advice and guidance point, this is all bound up with plans for hospitals across England to move to, as you mentioned, a single point of access model, or SPOA, from this year. NHS England says this is effectively a system that will simply streamline, simplify how GP referrals and advice and guidance requests are managed. But GPs fear it's going to add to workload because it'll push more work back to them from hospitals, and that it's essentially going to put a new barrier in place between their patients and access to specialist care when the GP thinks that's what the patient needs. So you mentioned a development on all of this, and this is the area where there's been some progress on advice and guidance and the single point of access issue. NHS England wrote to GPs and set out what the BMA described as a modified approach to advice and guidance that both reflects and assures the primary concerns of the GP profession. So NHS England promised that GPs' right to refer was unchanged, that changes to pathways as part of this shift to single point of access should be fully agreed with local GPs, And crucially, it said, as you mentioned, that there would be no national target for trusts to effectively reject a certain proportion of GP referrals via advice and guidance. Some earlier communications from NHS officials had talked about an aim to divert 25% of advice and guidance requests, like you said. So confirmation that this won't be a hard target is something that the BMA GP committee has welcomed. That's a step forward in terms of lowering the temperature between the BMA GP committee and the government. But as things stand, there's still no agreement on the BMA's other key ask around measures to mitigate concerns over workload linked to demand around same-day access for urgent patients that's coming as part of this year's contract, and the requirement that practices keep online consultation systems on throughout core hours, even if they're already at capacity, which was something that came in from last October.
Obviously, the BMA have welcomed that letter and that clarification from NHS England, but do you think the letter will make a difference? It talks about a lot of variation in how advice and guidance is working across England. Some areas where it really isn't working, with lots of complaints about poor communication between hospitals and general practice. One of the biggest complaints I hear from GPs in their day-to-day work is the issue of rejected referrals. And it seems to be a really common problem and something that's been getting worse in recent years. NHS England, like you say, is really clear that hospitals can't use this 25% diversion aim as an excuse to reject referrals. But do you think that will happen?
I think the letter does make a difference. But it definitely won't put to bed all the concerns that GPs have around how advice and guidance is changing this year. The advice and guidance DES from last year has been scrapped. So that paid GPs £20 per request, albeit from a limited £80 million pot for using advice and guidance. But this year that money's been dumped into practice core funding, but it hasn't been uplifted at all, despite the fact that NHS England has been really clear that it expects advice and guidance, or use of advice and guidance, to expand massively within this financial year. And moving that money into core funding means advice and guidance is now a core requirement for GP practices. So something they're expected to engage with as a routine part of what they do. The letter doesn't change all those points, which are making GPs worry about unfunded extra work. And to be clear, I don't think it materially changes NHS England's position on advice and guidance or on the move to a single point of access model. But what it does do is clarify some key points that will be really helpful for the BMA nationally and for LMCs locally in pushing back against how changes to advice and guidance are implemented. It makes clear that changes to pathways should be agreed with GPs, including through consultation with LMCs. It makes clear that requests for referrals should trigger a response from a named consultant. That's something that GPs have been worried about. It shouldn't be faceless, and it shouldn't be a non-doctor that's pushing that referral request away. It also reiterates some points we've reported earlier about a 5-day timescale for responding to a non-urgent query and a 2-day timescale for an urgent query. And it makes clear that a GP's clinical decision to refer remains unchanged. And as we've said, that there's no actual target to cut the proportion of referrals or advice and guidance requests that actually end up with a specialist appointment. It also acknowledges that in some areas, changes aren't being developed in collaboration with GPs. So having all of this in writing is really useful for the BMA and LMCs, because it means that if GPs need to challenge how single point of access is being pushed through in their area, they have all this to hold up in black and white about how it should be done.
We know that advice and guidance was a big sticking point for the BMA on this year's GP contract. As you mentioned, they were looking for concessions on this before the end of April, otherwise GPs would start taking action. We're recording this effectively as the BMA is about to meet to decide on what it's going to do about collective action. So there'll be some developments on that probably by the time people hear this episode of the podcast. But what does this letter from NHS England on advice and guidance mean for the BMA's next steps in collective action?
The letter from NHS England and the stance it's described on advice and guidance seems to have addressed a lot of what the BMA was worried about. So if the dispute about the GP contract was only about advice and guidance, I think it's fair to say that this would likely have been enough for the BMA to stand down over the potential return to collective action. But as I mentioned, there is another major sticking point that hasn't been addressed at all, at least as we record this. There's still no movement from the government on tackling unsustainable workload in general practice around same-day access for urgent patients and the requirement to keep online consultation systems on throughout core hours. GPs have said that just the online consultation system change, which pushed general practice back into dispute with the government from last October because it was implemented without safeguards that the BMA said were essential to protect practices from unlimited extra demand and being contractually required to keep working even when they were way over their maximum capacity. That change alone has caused big problems. We've reported on GPs having to work 20-hour days to cover an avalanche of online requests generated by that approach, which are not meant to include urgent queries, but need to be carefully sifted because they often do. And now this year's contract has come with this other lever that GPs fear will drive more unmanageable demand, the requirement for same-day access for urgent cases. NHS England has previously said that it thinks this won't be a big deal because GPs decide what counts as an urgent case and because it thinks that urgent cases are already generally dealt with as part of the roughly 45% or so of appointments practices deliver on the day that they're booked. But GPs aren't convinced, particularly after the experience with online consultation systems from last year's contract.
Yeah, as I say, by the time people listen to this, it will be more clear with what's going on with all of that. So do look at the website for the latest on that. Nick, you mentioned earlier that the NHS England letter said that these new single point of access systems need to be designed with local GPs. You've actually been looking at that this week. When do these systems need to be up and running? And are ICBs and hospital trusts actually devising these in partnership with GPs?
The letter is very clear about that expectation that the shift to a single point of access model and what that means for referral pathways should be co-designed with GPs. The letter said hospital trusts and ICBs must ensure that local GPs and GP leaders, for example, local medical committees, so it says that specifically, and interface groups are involved in the design and ongoing refinement of elective SPOA pathways. It encourages trusts and ICBs to bring specialists and GPs together to make sure that each specialty pathway works for both sides of that. And it's really clear that there should be ongoing and honest conversations, those are the words it uses, to keep refining how the changes to these pathways actually work in practice. But as I mentioned earlier, it also acknowledges poor communication in some areas and variation in how this change is being handled. And the GPs I've spoken to confirm that variation in approach. You mentioned the timescales for implementing all of this. Technical guidance for trusts earlier this year said that all providers are to implement elective SPOA by the start of October 2026, starting with the 10 specialties prioritised for advice and guidance and extending to other specialties and subspecialties. And it also said that providers are encouraged to broaden adoption beyond the 10 specialties, so it isn't limited to that. What we're seeing from talking to GPs is that ICBs are not hanging around. 2 LMCs I spoke to said that their area was starting to pilot an SPOA approach for some specialties from May. Other specialties are due to sort of come into play over summer. One said plans for the SPOA changes had been developed with no LMC input at all, although the ICB in the area said that it planned to involve the LMC and other GPs in future. I think the sense was, from the GP's perspective, GPs who work in the ICB had been asked, and therefore the ICB sort of felt that it was done in conjunction with general practice. But the point from the LMC was talking to a GP who works for the ICB is not involving general practice. Another LMC I spoke to said that it hadn't been consulted on the approach either to implementing changes, but that its members were involved in pilots that are due to start soon. So it expected to be kept in the loop and to have a chance to feed back its views on how those new pathways start to develop and how they work in practice. But I think it's clear that the sense GPs have of whether they can influence how any of this takes shape or vary from area to area. I think it's worth pointing out here that obviously influence in these sorts of changes depends on relationships. How good is the LMC's relationship with the local ICB and the big hospital trusts locally? That's something that will obviously vary, and that will have varied sort of since time began. But I think recent changes to ICBs are likely to have undermined some good working relationships too, in a way that could be really unhelpful here, just as they're potentially going to be unhelpful when it comes to setting up neighbourhoods. ICBs have had to cut half of their staff, and that means some channels of communication that GPs may have relied on just aren't there anymore. And with half the staff, you wouldn't be surprised if that contributed to some ICBs trying to cut corners on how they implement this and probably any other change that's on their plate at the moment.
I think that's a really good point, isn't it? I just think that losing all of those staff and those people with all that organisational and historical knowledge right at the time when the NHS is trying to introduce massive changes. I mean, we're talking about neighbourhoods coming on stream this year. That's a huge change. And this is a massive change in the way referrals works. And it seems like a really big challenge. So I can understand why people are quite concerned about how it might turn out and whether or not the hospital might end up with all the power still in those negotiations, which I think is what a lot of GPs fear. Alongside all of this, the BMA also published updated guidance for GPs on advice and guidance at the start of last week. That guidance advises GPs to query any referrals that are converted into advice and guidance requests inappropriately. The BMA said GPs should be asking for the name and GMC number of the doctor who made the decision to reject it or downgrade the referral. And so the BMA has provided a template letter for GPs to use to query any referrals that are turned into advice and guidance. What's interesting about that, the BMA says that GPs should save this letter in the patient notes where they can see it in the NHS app, and then this could help the patient themselves if they decide to raise concerns about the fact they've not been referred with their ICB, NHS England or their MP. That guidance also says, as we've been talking about, that LMC should be involved in designing any single point of access systems. There's a template letter in there that LMCs can send to hospital trusts and ICBs, asking them to confirm in writing that GPs retain their right to refer and that any workload shifted into practices will be appropriately resourced. The letter that LMCs can send is also really clear about the clinical risk of rejecting referrals. It talks about cases that the BMA is aware of where advice and guidance has been used as the only route for referral in some areas, and where patients referred urgently with suspected cancer had their referral downgraded to advice and guidance and didn't get a specialist assessment until the third referral when cancer was diagnosed. And this was 9 months after the original referral. So there are clearly some potential serious outcomes if these new systems are not introduced carefully. So next up, we're talking about GP partnerships, and that's because of a story Kimberley wrote about a private company called Operose Health, which has approached a number of GP practices and offered to take over running the practice. So Kimberley, can you explain a bit about who Operose Health are?
Operose Health is a private company that delivers primary care services in England to more than 700,000 patients across 82 locations in 16 ICB areas. It runs 61 NHS GP practices as well as urgent care centres from GP hubs.
Yeah, it's a really big provider of GP services, isn't it? And the story you wrote last week, what exactly was that all about? What have Operose Health been up to?
So the company has contacted quite a few GP partners telling them that Operose Health can take over their NHS contracts. Now, I've seen one of the emails that was sent to a GP partner, which was signed off by Operose Health's chief executive. First of all, it outlines some of the issues that general practice is facing at the moment and specifically points out the rise in workload and workforce shortages. And it also mentions the 2026-2027 contract changes. And it then went on to say that it is becoming harder for the traditional practice model to keep up with demand and maintain resilience. The email then goes on to use really quite emotive language and says that Operose Health can offer alternative solutions and can liberate GP partners from the increasing burden and responsibilities that are often associated with being a GP partner. So that's things like HR, estates, IT, and CQC inspections. The email then went on to say that Operose Health has supported lots of GPs to regain their work-life balance and focus on their patients without the burden of running a business.
Yeah, so this is basically a private company, isn't it, offering to take on practices which are currently run via a kind of traditional GP partnership model. So what's the reaction been from GPs about all of this?
The email comes at a time when we know the number of GP partners has reduced over the years, and the language used in the email, such as liberate and burden, has caused some upset online. One person said that general practice has become so underfunded and overregulated that a corporate takeover can be sold as a relief. They said, it isn't liberation, it's privatisation by exhaustion.
Yeah, that's a good lineup.
And another person suggested that this route could lead NHS practices being forced to go down the dentistry route where patients end up having to pay. I spoke to a GP partner who received an email from Operose Health, and he said he really didn't like the idea of private companies taking over NHS GP practices. But he did say he understands why some GP partners may see this as the only option available to reduce their financial risk. The Doctors Association UK GP spokesperson, Dr. Steve Taylor, described it as a creeping corporatisation of general practice that, in his opinion, will cause worse care for patients. And the BMA England GP Committee Deputy Chair, Dr. David Wrigley, told us that he couldn't see how private companies could offer the same level of care as the traditional GP partnership model. He even said that in the past, often companies operating NHS contracts have placed profits before patients. He went on to say that it wasn't right that the partnership model has been left to deteriorate. So that's what GPs think. For its part, Operose Health said that what matters most is that care remains safe, high quality and sustainable for patients, not the ownership structure. They said that any practices working with the company is because of GP partners' choice, and any agreements are made based on GP partners' circumstances. They said that GPs always remain central to the care provided. And they added that in some cases, Operose Health's involvement has meant practices have continued to operate where they otherwise may not have been able to do so.
This has been one of the most popular stories on the website over the past couple of weeks because I think GPs are really quite concerned about this and the kind of overall direction of travel and what it says about what's going on in general practice. But I think what the story really emphasises is some of the challenges facing the GP partnership model. It really reflects something we've talked about on this podcast quite a lot before, which you mentioned, Kimberley, and that's the really big drop in the number of GP partners in recent years. It also shows some of the challenges associated with the GP partnership models, in particular last man standing issues, which have been a problem for years and loads of people have said they need to be resolved. And what that means is that the last partner in a practice is potentially facing huge financial liabilities around things like redundancy payments and leases, for example, if there's no one left to take on the practice contract, and they are personally liable for those costs. And so that means, their house is on the line potentially, or things like that. When we're talking about succession planning in GP practices, which I did some stuff on last year on GP business, I did speak to quite a few people about this. If GP partners want to retire or step down, in the past what would happen is that the practice would find new partners to join the practice, and it would have been as simple as that. If that wasn't possible, which is something that's become more common over the past decade or so, then the default option is generally to merge with another practice. But mergers aren't always straightforward, and in part they've become more difficult now, I think, because of the financial challenges facing general practice now. Other practices are not going to want to take on a neighbouring practice if the figures don't add up, or if there are premises issues. There are all sorts of reasons why this might be difficult. So if a merger can't happen, then the only other option open to practices where partners want to step down is a third-party company like Operose taking on the contract, or joining a super partnership, or handing back the contract when then you'd be at risk of all those financial liabilities. There's no doubt that these third-party company takeovers have become more common in recent years because of that fall in the number of GP partners, I think. It's a really demanding job, heavy workload, lots of pressure around the financial side of general practice. So more GPs are choosing to step away from partnerships, not just because they're retiring, but also because they just don't want to be partners anymore. And it's also, I think, to do with the lack of new partners coming through, isn't it? Which is in part because of those workload and financial reasons, but also, I think, because of the uncertainty facing general practice at the moment about what's going on with the GP contract, the future of the partnership model under neighbours. I mean, it's a pretty volatile time to suddenly buy into a partnership, isn't it? So, you know, if practices can't recruit partners as part of their succession plan, or if a merger locally isn't an option, then third-party companies may be the only sensible way for some practices to go if the partners don't want to end up facing those liabilities. Talking about the partnership model, Nick, I think one thing that's also worth mentioning here is the UK LMCs conference, which is coming up in the middle of May. There's some motions on there that really point to fears about the future financial sustainability of general practice in the current climate in all 4 UK countries, aren't there?
2 standout motions from the conference, I think, underscore the level of concern in general practice at the moment around 2 age-old issues, basically the financial sustainability of practices and the way government policy is driving unsustainable workload. And one of the key conference motions talks about governments promoting an Amazon-style unlimited access model in general practice. To be clear, we're talking about the e-commerce company here rather than the rainforest. And the point GPs will be debating is that the government can't just keep promising more and more easy access to GPs unless it also looks at a step change in resourcing. And the scale of worry is evident in the other main standout motion LMCs will debate. And this absolutely links in with what Kimberley was just talking about with Operose coming in and the possibility of a dentistry style model that somebody mentioned along the way. And this is an argument that general practice within the NHS is simply no longer financially viable. And that as a result, GPs need to look at moving outside the NHS to mixed private state service, and that means that they can bring in more income in the way that dentists do. So that's literally the debate the UK LMCs conference is going to be having. There's very little prospect of LMCs actually voting for that motion, but the fact it's on the agenda should be a serious warning sign for governments across the UK about just how despairing many GPs are about the status quo in NHS general practice. If practice closures and the huge exodus from partnership roles that Kimberley's already touched on over the past decade wasn't making that clear enough already.
Were there any other motions on the programme that you think are worth looking out for?
I think some of the other key motions around workload again, the need for safe limits in general practice. GPs have called many times for safe working limits as part of their contracts. And we know that at the moment GPs are responsible for many more patients than the level many consider safe. BMA guidance has suggested a maximum of 25 routine consultations per GP per day and fewer if the consultations are complex. And LMCs are going to discuss agreeing advice along those lines that also specifies a maximum patient list per full-time GP that they can push for UK-wide. LMCs are also going to vote on asking governments across the UK to adopt safe working limits and on protections for GPs who take steps to limit unsafe workload, which many feel their current contracts are forcing them into. I mean, I guess one key thing is if the BMA in one part of the UK can negotiate their way to a government agreeing something like that, a safe limit, will it be a foot in the door, like a wedge that the BMA can use elsewhere in the UK to push that out across the whole country?
Definitely. So I mean, that's why it's really interesting what happens in other countries with regards to GP contract negotiations, because it often provides a blueprint for other countries to follow, even if, you know, you're not a GP working in those countries. The programme's a little bit different this year. It's not just all debates. So there are a couple of plenary sessions that look like they could be interesting. There's actually a session on the future of the partnership model, which is specifically looking at why newly qualified GPs are not choosing partnerships and how to make the partnership model more attractive. So given what we were talking about earlier and what I was saying, that's potentially an interesting session to keep an eye on. You know, it's going to be hosted by 2 early career GPs, so the focus will very much be on the next generation of partners. And talking about the next generation, there's also a debate about GP training, which I think will be interesting. One part about that is whether GP training should be extended to 4 years, with that 4th year focused on the business, contractual and leadership aspects of general practice. I mean, so that's another way you might be able to boost partnership if people understand more what's involved with partnership. But I'm sort of quite interested in seeing what people say as part of that, because I've been speaking to quite a lot of people recently, including on this podcast. And, GPs have told me that really general practice is now so complex that a 4-year training programme is probably more appropriate given how much GPs need to learn. On saying that, obviously there's a huge cost potentially associated with extending GP training. So whether or not governments would back such an idea, I guess, is the big question. There's also some interesting motions about AI and, proliferation of new software tools that may have unintended consequences around increasing GP workload, the regulation of these AI tools, and votes on whether practices should receive financial support to roll them out, which I think it's safe to say that last one will definitely get backed by the conference. I think one other one to look out for, actually, there's going to be a presentation, given what we were talking about earlier, from North Central London LMCs about a new system they've been developing there to help GPs manage inappropriate workload shift from hospitals. Obviously, as we've said, that's a key challenge in general practice at the moment. And it'll be, really interesting to hear what they've done and whether it's made any difference, and what the hospitals in the area, I guess, think about it all. Because obviously, if that's having some success, I think that's the type of thing we could start to see being rolled out across other areas, particularly, given all these changes with advice and guidance. Before we go, we've just got time for our regular good news story, which this week is about a practice in North Yorkshire that's been saved from closure. One of the reasons this practice has been in the news is because the local MP got involved in the case, and that person is none other than former Prime Minister Rishi Sunak. So, Kimberley, what's this all about?
So in early April, the sole GP partner of Reeth Medical Centre in Richmond, North Yorkshire, announced his retirement. On top of that, the Humber and North Yorkshire ICB said that it had been unable to find a viable alternative provider to take over the 1,500 patient GP practice, and that it would close at the end of May. Understandably, patients of the surgery were really unhappy with this, because for some it could mean having to travel up to 10 miles away to neighbouring GP surgeries. Just to paint the picture, this is a rural community, and there were concerns that it would be particularly difficult for people to travel far during the winter months, and actually difficult for older and more vulnerable patients to travel far all year round. One of the neighbouring practices said it wouldn't be safe for patients to be reallocated without any planning. So Rishi Sunak, who is the area's MP, became involved soon after the closure was announced, and he said he found it very difficult to believe that not a single GP in the country was willing to take over the practice. But then a neighbouring GP surgery called Central Dales Practice came to patients' rescue when it submitted an application to run a branch surgery from Reeth with the support of its fellow PCN practices. And this week, the ICB announced that it has approved the application. Now, it's not going to be the same service that the village has been used to. There are still some details to iron out, such as the location of the branch surgery, as it may not be held in the current premises being used in Reeth, and an opening date has yet to be confirmed. What we do know is that the Reeth branch will be open 2 days a week, on Tuesdays and Thursdays from 9 a.m. to 6 p.m, offering face-to-face GP and nursing appointments. Now, this is a really good example of general practices working together to help with long-term solutions, and it didn't go unnoticed by patients. When it was announced that Central Dales Practice would run a branch surgery from Reeth, people took to Facebook thanking the practice for saving the day and its determination to help the community.
Yeah, well, it's good news they found someone to take on that contract in whatever form. Obviously, we've talked about this in the office, haven't we? We've been talking about this story because it's a really good example, isn't it, about some of the challenges facing practices in rural areas, often which are very, very small. And as we've talked about on the podcast loads, it's very hard to run as a small practice now, given the way everything's changed. And obviously, those small practices are often in rural areas, and so potentially a real issue that's going to come up and affect lots of other small communities like Reeth as time goes on. Well, that's it for this week. Thanks for listening, and thanks to Nick and Kimberley. I'll be back next week when I'm speaking to Dr. John Ribchester, who is a GP in Whitstable in Kent, an area that's often held up as a good example of neighbourhood working, and somewhere that has really driven forward the shift of services out of hospital and into the community. I'll be talking to John about how the model works in his town, the benefits for staff and patients, and some of the challenges that need to be addressed to make working in this way easier to do. It's well worth a listen. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.